Hello, everybody. Thank you for listening to the Healthy Project podcast. I am your host, Corey Dion Lewis. I have a great guest in the building today, Chief Medical Officer of Broadlawns Medical Center and Vice President of Medical Affairs, Dr. Yogesh Shah. Dr. Shah, thank you so much for being on today. I really appreciate it.
Thank you, Corey, for inviting me.
Yes, absolutely. Like I said before, I've been really interested and excited to have you on for so long. But before we get into the topic at hand today, can you tell us a little bit about yourself and what gets you up in the morning?
Sure, yes, definitely. I did my medical school in India, in Bombay, big city of Bombay, many years ago. Now that city is called Mumbai, and then came to small town in Iowa, in Mount Air, Iowa, Corey. So the city I grew up, Bombay, the population was 11 million people when I left Bombay in 90s. In Mount Air, the population was 1,765. But I had to come. It was a selfish reason to do my visa conversion so I can get green card, but fell in love with Iowans in Iowa and decided to stay here. So, but during that journey, I realized I didn't have enough tool to take care of elderly Iowans. So went to the Mayo Clinic and focused on geriatrics, but came back to Des Moines because my wife said Rochester is too cold. So we came back to Des Moines and then practiced. And then opportunity came where I was asked to become the founding dean of global health at Des Moines University, which I did. Traveled around the world, saw the healthcare in many countries. And during that time, I focused and did MPH, Masters of Public Health, with the focus on population health and social determinant of health. And then now here I am at Broadlawns as the CMO.
Wow. And I think from what I understand, you founded the first palliative care program here at Broadlawns as well.
Yes, I did. During as a Mayo Clinic, I did my geriatrics, and part of that, I also took the national board for palliative and hospice management medicine. So I did find that group of palliative care here at Broadlawns.
That's awesome. And with your experience, Dr. Shaw, like it makes sense that you're in the leadership role you're in. And that's why I really wanted to talk to you specifically about, health equity and health disparities because of, the population that we serve at Broadlawns. So from your point of view, what does, we hear a lot about health equity, so what does that really mean?
Yeah, Corey, basically in some simple word, what equity, especially health equity, it means is consistent quality of care to anyone. So if I, as a physician, whether I see white person, black person, brown person, rich, poor, farmer, or a CEO, we are supposed to provide the same consistent care for their issue. I don't change based on who the patient is and provide. So that consistent care is the health equity. Unfortunately, in the US, we have significant inequity. That the health it's not provided equally to everybody, and it's inequal, and that creates a lot of problems. There are lots and lots of statistics, a lot of examples. Just to give you two important but meaningful things, that unfortunately the infant mortality rate and the stillbirth rate is much higher in African American patient populations. It's almost twice high in African American women compared to white Caucasian women, everything being equal, education and others. So that's a big worry for me. And the second area which Broadlawns we work on is mental health. That only 1/3 of African American patients have access to mental health compared to what they need. So So there's a lot of inequity in spite of, Corey, in spite of we spend highest amount per capita of our money. So just to give you numbers, $3.8 trillion, 3.8 trillion with T is our health cost. But still, and that's almost 10% of our, 20% of our GDP. You and me, on an average, it comes to about 20% of our gross domestic product amount for American. But still, we are not the best. So it's quite a concerning for me, both as a physician, as a public health person, and as a leader. It's a very concerning.
Yeah, my follow-up to that is, because you said something when you were talking, is that even comparing a Black woman and a white woman with same education, same everything, there's still this disparity. Why is that? What is going on that we feel like is causing that gap?
Yes. So what happens? And let me. It's a complex issue. Let me try to summarize by one phrase, one word. It's called social determinants of health, meaning that the areas outside of hospitals, outside of our clinic, where people are born, they educate themselves, they work, they retire, and then they pass or die. That area, that zip code, is called the social determinants of health. And unfortunately, what we do in our hospitals and our clinics is only 20% of our health. So your and my health and your listeners' health, it's only 20% is medical care dependent. 30% of our health is our behavior, which you know very well, whether what we eat, whether we smoke or not, and how much exercise we do. So that's 30% of our health. And then bulk of our health, 50% of our health, is the social determinants of health. In nutshell, Corey, it's your and my zip code and your listener's zip code. Our zip code where we live is more important than our genetic code.
Wow.
Let me repeat that. Yeah. Let me repeat that. There is a significant difference in how long people live. It depends on where they live, on our zip code. And it should not be. And that's what the social, so why the difference? It's that's the social determinants of health. That people unfortunately might live where they might not have safe neighborhoods. They might not have safe or good places where they can go and have healthy food. They might not have trail. There might be more gun violence, and that causes lot of age gap between how long people live. Just to give you an example, in Kansas, and there are lots of, the Robert Wood Johnson Foundation has done great work in this area. To give you an example of cities around us, in Kansas City, the difference between the richest and the best, healthiest zip code and the poorest zip code is 14 years of life. 14.
Wow.
In Atlanta, the similar would be 17. And same thing, and we think, oh, Iowa, we are all protected. No, in Iowa, that is about 7 years. The difference between the poorer part of Iowa and then the richer part of Iowa. So it's a significant thing, and luckily for Broadlawns, and that's where we are in one of the poorest zip code of Polk County, 50314. And our mission is to make our community healthier by we all working together.
Yeah, and that really played out during the past year or so with the pandemic, really trying to get the community healthier. What have you noticed, or in your opinion, how has the pandemic shone a light on health disparities and health equity? How is that? How do you see that?
Unfortunately, or fortunately, the pandemic has exposed all the issues of inequity to us. Meaning, just to give you again some numbers, the African American death because of COVID is 3.5 fold higher than Caucasian. A lot more African American and Latino had COVID positive compared to Caucasian. Multiple reasons. It's a multifactorial, and this is in Iowa, nationally, true, internationally, but also in Iowa. Three reasons mainly. One, the COVID has direct connection with chronic conditions. So if I am obese, I have uncontrolled hypertension, uncontrolled diabetes, then my chance of becoming positive because of this COVID is much higher. And that's what happened. That African American and unfortunately Latino community is higher on many chronic conditions. Second, that I it's my social determinants of health, meaning if now I'm living in a multi-generational homes, one person gets COVID, there's no room to quarantine or isolate that person. Now suddenly nine other family members are positive. Second, unfortunately, I didn't finish my high school education, so now I have to work job work where I have to work hourly job. I have to go and work, unlike hopefully us, where if I was positive, I could have taken time off, or paid time off, or PTO, and stayed home. Or my wife does that from home now. So that they couldn't do it. So I have to go and work to make my daily living, $10 to $12 per hour. That's second. And third, since I don't have car, I'm taking public transportation to go to my work. And now if I'm positive, or if it's even symptoms, I'm exposing many other people in the similar boat as I am. So that two big areas did affect and cause the COVID difference gap, a higher level, higher number in the African American population than it could have been. So there's a lot we have learned. The question then becomes what and how much are we going to do as a system?
Right. And that leads to my next question. You wrote a great article for the Des Moines Partnership. And in there you talked about in the earlier stages of COVID-19 outbreak, statistical demographics illustrated that COVID-19 disproportionately impacted Iowans of color. Hispanics and Latino Iowans comprised 2.6% of the state population. But in April 2020, Hispanic and Latino Iowans accounted for 16.4% of positive COVID tests. And Black Iowans, who represent 4% of the state's population, represented 11% of the positive COVID tests. So, my question to that, and there was a lot more. You talked about, upstream investments. One, how can we improve that? And what is kind of the health system's role in helping these communities of color?
No, great. So yes. So what the solution for these problems? Yes, for COVID or post-COVID or pre-COVID, what can hospital systems or we can do? That would be upstream investment. What does it mean? So what happens, Corey, unfortunately in our healthcare system in the US, every dollar we spend, so as I mentioned earlier, we spend $3.8 trillion for healthcare. And every dollar we spend for healthcare, we spend only half, we spend 50 to 90 cents for upstream investment, fixing our education system, housing, food security, transportation issue, and others. While in the developed countries around the world, especially in the European countries, for every dollar they spend downstream on health itself, they spend $2 upstream. That education is universal. transportation is available, food security is not a big problem. So what are the 4 to 5 areas I'm concerned about is, and not necessarily in that priority, is housing. It has studies after studies have shown that if I'm homeless, I am going to utilizing emergency rooms and hospital system more frequently than somebody who has a stable house. So housing is a big issue for health, of course, socially, but also for health. Second, healthy nutrition, not just starvation and hunger, but also healthy food. So that we have to focus on. Third, transportation. If I don't have my car, and if I don't have any public transportation near my house, in my zip code, to come to Broadlawns, I will tend to postpone my visit, cancel my visit, not go for my visits till I can find the transportation, because I don't have the money for Uber or cab. So that's an issue. The violence. Unfortunately, some of the poorer zip codes have also more social violence. So, and the fifth one is, hopefully it's getting better, is utilities. If I have a home, but I don't have appropriate air conditioning now, talking about air conditioning, tomorrow it's going to be 100 plus. But if my AC is not working, of course I'll have some health issue, and then I would not have transportation. So those 4, 5 areas, if we can work on as a healthcare system, slowly but surely will improve our health. So what is Broadlawns doing? Luckily, Broadlawns has done significant work in this area. We call this program as a teach and tech program.
Yeah.
And what that stands for in short is, we train high school graduates, or people who are going to graduate in 10th and 11th, to give them the training in health field through giving them certified nurse assistance program, CNA, free through Broadlawns. Similar internship we do for adults. We call it teach for adults, where adults who might not be able to find regular job because of their past, their maybe misdemeanor or minor felony, we train them for the similar CNA program, where after acquiring this certificate, they can work within Broadlawns or work in some of the other healthcare systems. So slowly, by some kind of programs like that, where I finished my high school education, I'm now working, that overall system will slowly get better.
Yeah, and a big shout out to Dennis, who kind of runs that program, and you see the benefits. I've heard from alumni or people who've gone through it to say this has been the best paying job I've ever had, and that allows them to do some of the things we've been talking about. It allows them to have a better place to live. It allows them to maybe eat healthier or do some of the things that they couldn't do before. And there's a kind of there's a confidence booster for feeling like you're not only do you have a job, you have a profession, you're doing something that's good for the community. So that is awesome. Dr. Shah, the pandemic, we've talked about a lot of really serious issues, but what are some what's the light at the end of the tunnel? What are some positive things you see? We've talked about the Teach and Tech program, which are great. What are some positive things that you see that are going on now that that we can be kind of proud of and see that there is that light at the end of the tunnel?
Good, Corey. Yes, there is light at the end of the tunnel, and there is always few positives out of any disaster. So there are a few good. Let me point out 3 to you. One, due to this pandemic, I personally realized, and we all realized, the strength we have within our people, within our team and leaders at Broadlawns and outside. So we, in a very short time, I was able to bring 20 leaders within Broadlawns and meet regularly, almost every other day in the beginning, every week afterwards, to talk about how to tackle this new condition pandemic. So that's teamwork within, the teamwork outside. We, the chief medical officers of 5 major systems, Broadlawns, Mercy One, Unity Point, the VA, and Iowa Clinic, we were able to come together very quickly to work as one team and come up with policies about how visitation, when should we not have visitors come in, when should we stop the surgeries, elective surgeries. So that became, teamwork became very obvious. That's a positive. Second, we were forced to use telehealth more frequently than normally we would have used. And that telehealth helped, especially for behavior health, helped to cut down our no-show rate significantly. Before COVID, because it was all in person, our no-show rate was anywhere between 20 to 30%. People just couldn't come because of transportation or other issues I mentioned. But with that telehealth, that issue was kind of taken care of. So our no-show rate drops significantly. So that's a positive, and telehealth is here to stay. And the third thing, which is I'm very proud to say that's a big success, is both within our community, statewide, and maybe nationally, is that we were encouraged to work outside of our wall. And in our case, Broadlawns developed a very positive partnership with Corinthian Baptist Church, happens to be in our neighborhood, happens to be mainly for African American population, and one of the largest. And we had a very successful free vaccine clinic on March 27th within the church premises, which became a great success. More than 1,100 community members came. 60% happened to be African American. And that model now has become such a success that the state governor and others are asking us to look into that. How can we develop faith-based communities and health-based communities work together to take care of some of the social determinants of health issues?
Right. You got to go where the people are.
Exactly. Good point. You brought up yes. So what else have we learned from COVID? Few things. One is we have to change our model and go where people are, telehealth, because they can't come to us or they will not come to us. Second, we have to do better planning about how to care our elderly, whether they are in nursing home or they are living on their own, because we realized that they unfortunately became very vulnerable with this new virus. Third, we do good job, but COVID made us more realize that we have to talk in the interracial language, not just in their language of their mother tongue, but talk where people and how they can understand. Because COVID, everybody had different view about COVID. Some people say, hey, in the beginning, many African American population people I talk, they say, hey, it doesn't affect us. It's mainly disease of the white.
Right.
So just telling in English that, hey, no, it's for everybody, doesn't help. You have to understand why that's coming from. So we learned a lot on that.
Yeah, absolutely. And even, from, even speaking with people from other cultures about, COVID-19, or even about their health in general, if you can't speak to them in a way that they understand, it's not going to get all the way through, and you can't really help that person if you can't really get through to them. So sometimes you have to, like we've been talking about, come to where they are, and like you said, speak how they speak, so we can actually make a true impact.
So true. So we have learned that, and Are we doing it all the time? No, but at least we are aware of it, and slowly
Mhm.
we'll make it part of our system.
Yes, absolutely. Dr. Shaw, thank you so much again for your time being on the podcast. If anybody listening wanted to get to learn more about Broadlawns, the things that we're doing, get to learn more about you, where can they connect with you at, or where can they find you?
Sure, definitely. I'll give you a link to the video, which we summarizes what we just talked, and give some more numbers. So I'll send you that. Feel free to send it to your listeners, and in that is also my email and contact number. People can contact either you, and you can forward the questions or concerns to me, or directly email me.
Awesome. Awesome. Well, again, hey, thank you so much for your time, Dr. Shaw. And everyone, thank you for listening. I'll let you next time.
Thank you.